Maximilian University in New Orleans. He's director of cornea service at Comprehensive Eye Care of Central Ohio in Waterville, Ohio, and clinical assistant professor of ophthalmology at the Ohio State University in Columbus. And we asked everyone to give a fun fact, and this is Ken's fun fact. Ken, any comments?
I never used the word expert. I think I said mediocre. You upgraded me.
Well, I just figured, I mean, if you're sharing that you're a harmonica player, it must be something that you're quite talented. So we're lucky enough to have Ken, who's a close friend, and super excited that you're part of the Rising Stars tonight.
Thanks.
So next, of course, we're going to have celebrity panelist Mina Massaro. Mina, just to share, we both trained together during our residency, but she went to medical school at Temple and then did her residency at one of the best programs in the country at University of Pennsylvania Shea Eye Institute. I'm not biased at all. Then she did a fantastic mini refractive fellowship with Eric Donenfeld in New York. And she's currently back at Shea Eye Institute. She's the co-director for the Penn Dry Eye and Ocular Surface Center. And she's a professor of clinical ophthalmology at the Perelman School of Medicine, University of Pennsylvania. And Mina is kind enough to share her fun fact. And I was asking for more details, but this is what she shared. That their fun fact is she's an expert at hip hop dancing and curling. Mina, can you share anything about that?
Yeah, once again, I didn't say expert. I said these are things that I enjoy. And hip hop dance, I've done, being a New Yorker, that's what we do. We hip hop all the time. And then curling, the Olympic sport, that's always a lot of fun to do all year round. In Warminster, Pennsylvania, we have a wonderful league of women that get together and we work out our arms and we're on the ice. We have a little bit of wine and we have a good old time.
Wow. We do not have curling in Miami. Aspen? I don't know. I'm not sure if Aspen has that in his hometown either, in Chennai. So, well, thank you. No, thank you, Nina. We're so excited that you're here. And then, of course, we're going to introduce our third celebrity panelist, which is Jim Katz. Again, a very close friend. We get to go to so many conferences together. He went to medical school at, oh my gosh, of course, I apologize, at the University of Illinois. Sorry, University of Illinois College of Medicine. And then he also went to University of Illinois Eye and Ear Infirmary for his residency. And then did a cornea refractive and anterior segment fellowship at the University of Utah, which is the Moran Eye Center. And he's currently president and medical director of the Midwest Center for Sight in Chicago. And Jim's fun fact is he is actually an expert skier. So he is the region medical advisor and he's an active member of the National Ski Patrol. And I can tell you he's a great skier and just a phenomenal person. So do you have any comments on your being part of the ski patrol?
Well, I've done it for quite a long time and it really keeps up on things in medicine beyond the eye and keeps up on skiing. So I love seeing you and others when we go on our ski trips.
You also do cataract surgery on a fish.
This is another story for another time. That's true.
Okay. That'd be fun fact number 2, which will next time you're a celebrity panel, so we'll have to tell us more details on operating on fish eyes. And of course, we have our rising star, Yuna Rapoport. So we're so excited that you're here. You went to college at Northwestern University. Your specialty was you were in the honors program in medical education and economics. You then went to medical school at the Northwestern University Feinberg School of Medicine. You did a residency at Vanderbilt Eye Institute, and then did a fellowship in cornea refractive surgery at the Mass Eye and Ear. And your current position is cataract refractive and corneal surgeon and director and founder of Manhattan Eye. And Yuna's fun fact is this is one that I need you just to share because instead of me reading it, I want you to describe your juggling abilities.
Oh yeah, I had an extensive juggling career before ophthalmology. We had a club in med school called the Jugulars, and I could barely keep up. People juggled clubs and 4 balls and 5, and I could barely do 3, but I somehow was able to do them on stilts, so I was allowed in. And we performed at the Children's Hospital and a few performances, and it was great fun.
Oh man, that's amazing.
Very random.
Rare talent.
Awesome. I don't know. I have to see. Maybe you should bring stilts to one of our next meetings. We'd love to see you on stilts and juggle. That could be a lot of fun.
As long as they can fit in my carry-on. Maybe they're as long as my skis, so I'll check them this time. But
Oh my gosh, too funny. So we're lucky enough that you shared some really fun pictures. So if you don't mind, at this point, we usually have you just run through the photos. We have a couple pages. So if you want to share a couple of these photos from your life.
This is my family, my parents, my brother, my cousins, my aunts. Photo of my dog there, Bowie. You can sort of see there. He's on the computer and sick of his presbyopic glasses, getting ready to get rid of them there in the middle. So just, people close to me and Bowie, my dog.
Oh, so fun. And then the next, I love this set of pictures.
So some of my hobbies outside of ophthalmology, I'm also very passionate about skiing, not on ski patrol, have to travel for it, but really, really enjoy it. Also into hiking. That photo on the top left is actually me climbing. That's a practice round for climbing the Grand Teton with my dad this past summer, which was really cool. Into scuba diving as well, and photography. Those are a couple of shots of mine of bison from Yellowstone National Park, which was really special. Into painting as well. And the top right photo is me and my friend Mort Gerberg, who's a New Yorker cartoonist. And we're working on a book together of pun cartoons. So that keeps me busy as well.
Oh, that's super fun. And then this set of photos.
Yeah, so this is actually a little bit of how I became interested in ophthalmology. I took a year off after my first year of med school, which is a little atypical, and I was working on a master's in public health at that point. And I went to, obviously, everyone's heard of the Aravind Eye Hospital, and they have a lot of community hospitals, and this was the Arsan Eye Hospital in Erode, India, in the southernmost state of Tamil Nadu. And I went more as a public health project to try to help a Ghanaian ophthalmologist start a similar cataract camp system outside of Kimasu in Ghana. And while I was there, the pathology in India, I mean, Ashwin, I don't have to tell you, it's fascinating. Those lenses are so incredibly dense, and the cataract surgeries were fascinating, and the corneal ulcers were so diverse. So while I was there, I thought, wow, this is a great field. I went for the public health aspect, and I sort of kept it in the back of my head while I went back to my second and fourth years of med school. And here we are, I don't know, a couple decades or a decade or so later. So yeah, it stuck with me. And I've been back
Beautiful.
since to Nepal and to India to sort of learn small incision cataract surgery, and also to teach phaco. I think Dr. Katz, you have a few clinics in Vietnam, is that right?
Yeah, so we started a sustainable project in Vietnam a number of years ago with our state society, and we actually got support from the Ministry of Health as well as doctors in Illinois and industry. And we got them involved and set up a program where over the next 3-4 years, we were able to teach enough of the doctors so they could teach themselves how to do the phaco. So we'd go again and again, and we kind of stepped back over the years and allowed them to take over the program. And it's now sustained in Hanoi.
Wow.
That's
Yeah, skills
wonderful.
transfer is the best thing you can do in these medical mission trips, definitely.
Yeah.
A few of my mentors over the years, the top left, that's Dr. Jonathan Davidorf. He's in private practice in my suburb of West Hills, California, and he did my LASIK. And he, when I was in med school, I'd come home and say, hey, Dr. J, I'm thinking about anesthesia. I'm thinking of, neurology. What should I do? And he's like, well, I'm biased, but ophthalmology is the best by far. And now I get to see him at meetings and call him a colleague. So that's great. Bottom left, that's Dr. Paul Sternberg. He was chairman at Vanderbilt Eye Institute, very influential to me as well. Of course, in the middle, that's Dr. Klaus Dolman, the famous Klaus Dolman. I was his last fellow class at Mass Eye and Ear, and I remember he, a patient would walk in the room and he would, remember every detail of their clinical history and their social history. And then that's my last day operating as a fellow with Dr. Roberta Pineda on the right.
Beautiful.
And I had great mentors along the way. And I actually have a program where I have pre-meds and medical students rotate with me as well. And they're brilliant students from NYU and Barnard and Columbia and all over New York. So, it's great giving back.
Beautiful. And these photos are quite interesting.
Well, so this is kind of interesting. I did a little bit of media with specifically with refractive surgery, and the Dr. Oz bit I thought was so interesting because the patients who were on that show came in who had LASIK complaining of terrible neurotrophic keratitis, terrible dry eye. And some of the complaints were not pathophysiologically based, like floaters and things like that. But it seemed to me that there were a lot of myths to debunk, and had a very interesting experience on that show as well.
Beautiful. Well, that was a great overview. Thank you so much. So we're ready for your presentation. I'm going to end share. And if you could jump in and share your screen.
Awesome, Yuna.
And these are our sponsors. So we always appreciate that supporting us. Allergan, Alcon Devices, Dompe, Avellino, Young MD Connect, Sun Ophthalmics, and Tarsus. We appreciate all the support for our season 3.
So thank you so much for having me on, and thank you so much to the celebrity panelists. I'm sure we'll have a really wonderful, robust conversation, and everyone's going to have some great insights. So it was partly that experience on the TV shows, but also knowing that there are limitations to some of the refractive procedures I was offering between LASIK and PRK, with dry eye and diopter limitations and neurotrophic keratitis, that led me to explore some other refractive options recently. And so I wanted to focus on my journey, incorporating and learning new techniques. I think we're so fortunate to have incredible surgical training when we go through residency and fellowship. But what happens when you're out of training, and there are inevitably going to be new techniques that come out that you want to learn, that you want to offer patients, and you want to offer the best possible care to patients. And so how do you go about seeking out the education yourself and incorporating it into practice? So that's going to be kind of the goal of this conversation. So I'm going to jump right into it and ask our panel, Dr. Beckman, what surgeries and areas of interest did you have in the start of your career that then sort of organically faded out, if any?
Well, when I did my fellowship, glaucoma was a big part of our cornea fellowship. So I was doing, as a fellow, we were doing tubes and trabeculectomies. And over time, I just evolved away from those as I started building up more of my cornea practice.
Yeah, that makes a lot of sense. I had a lot of corneal training, and was doing DSEC and DMEC, and kind of gave that up because became a little bit more interested on the refractive side. And Dr. Massaro, what new areas of interest or procedures have you been able to grow in your practice, and how did you make that happen?
So as a comprehensive ophthalmologist and a busy cataract surgeon, I was very happy learning all the new techniques for cataract surgery and trying to make people happy, getting them to see better. But many times they weren't happy because their tear film was a mess. So I sort of jumped into the world and tried to really make their tear film better right from the start, and developed a big ocular surface center at Penn. And the procedures that I sort of incorporated were pretty much all of them, from intense pulse light to LipiFlow to tear care to devices that stimulate nerves, whether it be true tear or the external devices or chemical stimulation of the anterior ethmoidal nerve, and just pretty much getting an understanding about what is the deficiency in their tear film? Is it more a tear insufficiency, or is it more of a meibomian gland issue? And trying to pinpoint what the problem is, and then offer treatments for these patients, and have also all the diagnostic tools to help decide what their actual problem is. So dry eye has become, and sort of I faded away from doing cataract surgery and really into the dry eye world to help stabilize their tear film the best that I could.
And was it easy or difficult at an academic center to bring in all of these technologies and devices?
Tough as heck, because many times they're like, stick to doing your cataract surgery, all these pieces of equipment that you need, all these machines are quite expensive. What are you going to do? I said, well, thankfully I have some grateful, wealthy patients, and I raised money with them and fundraisers, and I was able to actually purchase many of the equipment on my own. But it was essential. It was essential for my mission to develop a dry eye center and get these pieces of equipment. And yes, it was challenging, because as an academic center, they have a budget and their vision was a bit different from mine. But over time, they saw how the center grew and then started to help me buy other pieces of equipment and support my mission.
That's, yeah, very impressive. I'm sure challenging with an academic center. So, with that being said, the new technologies that I wanted to implement were SMILE and ICL, because I thought that existing procedures had limits. LASIK is wonderful. I had it done myself. I think it's a great procedure, but we know that with an average pachymetry and normal topography, you can really only treat up to a 6.5-ish prescription. So that's limited for the higher myopes. You definitely have some ocular surface disease, even if you pre-treat afterwards, because we are going through corneal nerves. And I do an incredibly thin flap. I do 82 microns, which decreases that risk. But that being said, you're still stimulating some ocular surface disease afterwards. You need a perfect topography. There's issues sometimes with flap complications. It requires very strict patient compliance, really that first day, as we know. And I've refloated many a flap that were perfectly adhered when they left, but patients rub their eyes, etc. And certain lifestyles are excluded. This sounds silly, but jujitsu is having a moment in New York City. And, I've had quite a few patients who come in who have certain activities that I just don't think I want a flap on their eyes with their activities. Obviously, the benefits, I think it treats hyperopic prescriptions the best, and it's an incredibly quick post-op. Most of our patients are young, they're working, they're in school, and they want to go back to their day-to-day life the next day. And with LASIK, they really do with that vision. And PRK, of course, the benefit is that we can correct up to a -10, maybe even more. I sometimes combine it with cross-linking for keratoconic or form-fruste keratoconic patients. We know that there's definitely less risk of corneal ectasia than with LASIK or SMILE. The topography doesn't have to be perfect. But I think the main limitation is such a high discomfort profile. I mean, patients are so uncomfortable in the first few days afterwards. I usually counsel that you have to take 3 to 5 days off, and this patient demographic wants to get right back to their busy lives. And at the higher diopter corrections, you have risk of post-operative haze, even if you're using mitomycin C. At the higher prescriptions, you have a greater risk of higher order aberrations as well. So yes, you can treat up to 10 diopters even more, but at that higher correction, I thought maybe there's something better for these patients. And so what I wanted to ask Dr. Katz is, how do you decide when to recommend PRK, and how does dry eye influence the procedure you will recommend sort of between PRK and LASIK or anything else?
Well, first of all, that's a great summary of the procedures, and I think we're going to get into some of the advantages and disadvantages of each. As far as PRK versus LASIK, once in a while, a patient will actually come in asking for a surface ablation, and they'll fit into it. I go with it. I stick with it. I certainly will go over the other options, including, ICL and EVO, potentially SMILE and LASIK, of course. But again, I will go with what the patient wants in that case. And as you also know, with the thinner corneas, sometimes there isn't enough tissue to actually go on and proceed with LASIK. And you also mentioned those types of patients who might have injuries or injury prone, and we want to avoid the LASIK. So those patients certainly go into, but really it comes down to when I recommend it for how high a correction it is, usually myopic correction. So if it's a high myopic correction with a thinner cornea, so I go by the residual stroma that I'm going to be leaving. And really I give the option to the patient. And sometimes they'll go with PRK. Most will go with LASIK still to this day. When we originally started doing LASIK, we were doing almost exclusively LASIK. And there's a percentage that probably do 20-25% PRK now for those types of patients. Then again, the surface issue. So when we talk about potential of dry eye, some people will want live in climates that they'll be more concerned about those types of things. And we're really going through less nerves when we go with the PRK procedure. So there may be less dry eye overall with those procedures too. So I kind of balance talking to the patient, seeing what they want and how high myopia they have compared to what the residual stromal bed is.
Yeah, that's a perfect summary. Couldn't have said it better. Thank you for your insight. And then finally, refractive lens exchange. The benefits are that you can treat very high, very low prescriptions. There's no dry eye. You're not ablating the corneal surface. There's no or very few higher order aberrations from the cornea. And you can correct for presbyopia. So it's excellent for the 45 to 65-year-old patient group, which doesn't yet qualify for cataract surgery. But the limitations of RLE, it's in my opinion a higher risk profile. It's comparable to cataract surgery with the risk of endophthalmitis and serious complications, inflammation, glaucoma. It's a lot more expensive for patients. We do unilateral cases at the ASC, which is A, more expensive, B, more time consuming for patients. You're already taking patients who are at higher risk of retinal detachments that are usually myopes or higher myopes and adding an extra risk factor there. And, there's also the IV anesthesia. I sometimes do this with just oral Valium, which, most of these patients are fine with that, but some patients do elect to have IV anesthesia. Dr. Beckman, are you performing RLE? And I'm curious to hear what your go-to lens choice is.
Well, actually, I'm not really doing these cases. And I think that your description is excellent. I think that the big risk, again, the RD is the big thing. So you have a younger patient who's a high myope who's already at high risk for RDs. So I cannot tell you what my go-to would be for these since I don't do them.
Dr.
What about
Katz,
hyperopes? Okay, but same for hyperopes?
I'm sorry. Well, then in hyperope,
I said, what about hyperopes?
Yeah, so in a hyperope, you're getting to the. It's not that I'm not doing it because I'm not okay with it. I just personally don't have that as a part of my practice. The hyperope, you have the other issue. If they are so hyperopic that you don't think they're a good corneal refractive patient, then they're going to maybe a small eye and have the risks that we see with those types of eyes. So no free lunch on any of these. The small eye with a shallow chamber and the cornea risk. So you have to keep all that in mind when you're making that assessment as to which way to go. There's a reason why they're not good candidates for laser in the first place, and those and along with that, they are not good candidates for some of these procedures. So you find the right person. It can work really well.
And there's also a little bit of risk of dry eye too. No matter what, you're still making a tiny incision. You're needing to treat them afterward with medications, especially if they have a predisposition for being dry. So there also could be a little bit of surface change and problems.
That's true. However, a lot of these patients wear contact lenses, and I find them being out of their contact lenses, they're actually more comfortable overall. Long term, all these things that are mentioned can happen. I feel comfortable with, especially the hyperopes offering these procedures. A lot of times patients don't take me up on these because they're quite costly, but I bring it up to them to let them know that we can do these things early, because they're finding out, especially when they have very, very subtle or mild cataracts that would not be covered by insurance, they're learning that at the same time we can reduce their prescription. They get it, what we can do for them. So in addition to going over what those risks are, I let them know how expensive it is to do it. But on the other hand, they can get the results now instead of waiting another year or 5 years or 10 years. So especially in my practice with the hyperopes, I will go with that. The younger patients, I often will do a kind of extended depth of focus lens. For those patients, I find some of the patients under low 60s with larger pupils have a higher incidence of the haloing, which they really don't like. It's not even the incidence of it, but how well they tolerate it. So we spend a lot of time talking about those kind of things, because anyone over 45, you typically would want this type of procedure over a laser vision procedure because they can get the benefit of intermediate, maybe near vision out of it. So I think that's why we're describing these procedures of refractive lens exchange over a kind of static procedure like a LASIK or SMILE or something like that.
Yeah, and I think it's very important to know what patients do for a living and for fun, because people who have different lighting requirements might not do well with extended depth of field lenses, and you might sort of opt for a monovision or a mini monovision situation with just a monofocal lens. And I think with all of these limitations that we talk about, no surgery is also an option. You know, you don't have to operate on everyone who comes in wanting surgery, and you sort of have to really pick and choose carefully, because at the end of the day, you know, if someone's not happy, that's something that, you know, is a bigger issue than a patient with contact lens discomfort, in my opinion. So that's always important, I think, to remember. So with that in mind, I wanted to explore Smile. What can Smile offer to my patients in my practice that these other procedures couldn't? The demographics and the candidacy are similar as LASIK. So, you know, over 21, the same prescription for a year, not during pregnancy or nursing because the prescription is changing. No other corneal issues like dystrophies. It's interesting with a history of a herpetic outbreak. You know, I think there's interesting data on LASIK with a previous HSV keratitis. There's only been one presumed HSV reactivation in Smile that has been reported. I'm sure there are plenty of others, but that's something else to consider. The prescription that you can treat is from a -1 to a -10. So you're increasing the diopter candidacy. However, it's still the same residual stromal tissue that you have to have. The astigmatism is interesting, and this is a little bit of a restriction. So you can only correct either 0.75 or nothing. So I take very good care in refracting these patients several times, because if someone is a -0.5, you're either committing to them having that astigmatism and treating 0.75 and flipping their axis, or you're saying, I'm not really sure they have this astigmatism to begin with, and so you're not treating it all, you're not correcting it all. And there's no hyperopic treatments that you can do for Smile. I think the benefits are there's no post-op restrictions whatsoever. My patients go home without even a shield. There's no flap complications. I tell patients, you know, go skydiving tomorrow. You're, from an eye point of view, you should be fine. The beauty of the Zeiss Visimax laser is that there is no suction. It's a very gentle applanation. There's no pressure increase to the 90s with a loss of vision when the nerve doesn't get perfusion for that split second, which you do have with the other LASIK lasers. Obviously, you can do LASIK with a Zeiss Visimax laser, which I've been doing. But if you're using a Vizx or something else traditional, you do have that loss of vision. And you can also get the subconch heme from the suction as well. I do think that the vision at -10 with Smile, or at the higher prescriptions, is better than it is with PRK. So I think from everything else, you know, if the topography is a candidate for Smile, then I will always offer Smile over PRK, because I think the vision is better, and I think that it's a more pleasant recovery course. And really the main benefit is that there's, I don't want to say no dry eye, because you are still creating a small flap, and, you know, you have drops with preservatives afterwards. And like Dr. Massaro said, none of these procedures have no dry eye, but it's significantly decreased. And that cartoon on the top right is sort of what I show patients when just showing them this image of the comparison of the minimally invasive 2mm incision with Smile versus the entire flap. And patients sort of get that idea that you're going through more of the corneal nerves. But with Smile, there are no topo-guided treatment options available. So depending on what your thoughts are on that, you know, that's not an option. So, okay, I decided to implement this. I think it's a great technology. What next? So I'll briefly go into this. I found a Visimax Zeiss laser in the city with someone willing to do a click fee model. And this is sort of what you do when you're in solo private practice. How do you actually get this off the ground? I reached out to our local Zeiss rep. That's him right there, David Skalke, who trained me. He is amazing and always available. Very strict protocol. You have to do 50 flaps for regular LASIK with the Zeiss Visimax laser. The positioning in Smile is a little more sensitive. It's more challenging, as we'll see later on. It's less forgiving. You need a lot of patient cooperation. So that's another reason to choose some patients for Smile and some patients not for Smile if you don't think they'll be able to cooperate. And a little bit more verbal anesthesia is what I call it. did a ton of videos, did a wet lab, did our first patients, and a little bit was trying to talk to my surgical coordinator about how to involve offer these procedures to our patients. And previous mentors are always available, as well as David. So this is just an image of the Zeiss Academy, which is their online training that took a lot of time to do. And this is sort of a question for whoever wants to answer, but once you decide to offer a new procedure or technology, how do you train your staff to talk to patients about it? Because as we know, we're not the ones booking the actual cases, and a lot of the questions are being asked to our staff.
This, if you don't mind, I'll jump in. This is an issue with really anything you're bringing in the office, and it's not just procedures. It's even with managing your post-ops or dealing with dry eye patients. You really have to make sure your staff understands the condition and understands what you're trying to do. It takes a lot of time, education-wise, getting information from the company that provides the service is also very useful. For me, the closest thing I could think of is when we started cross-linking a number of years ago, and we do, hundreds and hundreds of these. It takes a lot of time to explain to the patients. It takes a lot of time for the technicians to go over everything. And over time, they've gradually picked it up. But I would recommend getting them as much time in front of the company that provides the equipment, have them listen to them, have them get online, have them produce as much of their materials that you can give to the patients, have access to links to websites that'll go over all of the necessary stuff for the patients to do. And because I could not survive without them taking the time to do that. It just takes too long. And so that's really the key, is you just have to get your techs trained as well as you can, as quickly as you can.
Yeah.
I think it's a great question, Yuna, because this is really what it comes down to. We can pick and choose what type of procedures we want to do, and of course, what we think is in the best interest of the patients. The way we implement them and the workflow in our practices means so much to patient acceptance. The consistent messaging that our staff can give the patients really induces a level of confidence that they have even before the procedure, knowing what side effects they can have after the procedure, reducing callbacks, having patients feel better about the results that they're getting. So I think all the things Ken said are super important. Going to the rep, using the materials they have, really gaining the knowledge within the practice. So again, you can implement this thing. You can't just learn the procedure, then expect the staff to understand it. The patients will be almost scared away. They have to hear the same message. Often people come out of the room after you spend a lot of time with them, and the scribe will walk them up to the front, and the scribe will say, what do you think I should do? They're asking the tech or the scribe after the doctor talked to them. So they need that consistent message about what we recommend for them. So I think this is, again, very important for all the viewers to listen to and understand.
Yeah, very, very helpful insights. Thank you. So we talked a little bit about this. This was expanding candidacy. This is actually my surgical coordinator, Stephanie. She had terrible dry eye, and we did Smile for her, and she was thrilled. But in addition to the higher diopter categories, I feel more confident doing Smile with a history of HSV keratitis for the reasons I mentioned, the severe dry eye, and patients who have become contact lens intolerant. And Dr. Massaro, I wanted to ask you, what steps do you recommend to patients to improve their ocular surface health prior to cataract or refractive surgery? Do you have sort of a set standard practice for perioperative patients at all, or does it vary from just general dry eye patients?
Yeah, well, it varies for, each patient. And of course, if they're going to undergo any type of surgical procedure, a thorough evaluation and an excellent history too. It's important to ask if they've had any other surgeries. Do they have any depression that could affect, nerves? Are they on any immunomodulating or any medications that can affect nerve function? I think the history is key. Have they had, dry eye in the past surgery? So I think history is number one, and then a very thorough questionnaire to ask about how dry they are. And then thorough slit lamp examination that starts with external, really looking at the lids, averting the lids, see if there's anything underneath the lids that can be causing trouble or scarring, aggressively treat any lid disease, blepharitis, meibomian gland dysfunction, whether they have Demodex, really clean out the lids before any surgical procedure. And, if there's still some question of stain on the surface, I stain everyone with lissamine green and rose bengal and fluorescein and, tear breakup time, taking osmolarity, and really improve their tear film, which means sometimes putting them on a short course of an antibiotic steroid drop or start them on an immunomodulating drug, which can take a bit of a time. But that time you put in is well invested, because the last thing you want to do, well, first of all, if you're going to be taking measurements, you want a nice healthy tear film anyway to choose what kind of implant that you're doing. And you really want to approach any surgery with a good, healthy service. So even if that takes 1 or 2 months to do to get them under control, that's time well worth spent. So everyone goes through a very thorough evaluation, whether they're surgical or even post-surgical, or whether they're the run-of-the-mill dry eye patient. I spend a lot of time with them at a chair time, trying to let them understand what their disease is, because many times it's not just dry. It might even be a lid that needs to be fixed, or allergies that are on the surface of the eye that need to be treated. So it's not just about, like I said, the dry, but other things that you're dealing with, and a long conversation and very aggressive treatment.
Yeah, I couldn't agree more. I think, pre-treating to get accurate measurements is the most important thing you can do, because you can be proficient at this procedure, but if the measurements are even a tiny bit off, that's not a great outcome. So I think going slow to get the outcome you want is very important. Thank you. So I'm going to go quickly through these steps. So here's a little cartoon image of the lenticule. So the posterior aspect is made first. We see that happening right now. And then the anterior is about to start over there. That's the cap cut. That's the anterior portion. And during this time, I'm telling the patient to look at that green light. The last step is that cap opening incision right there. So very important. That's how it should look. Okay. So did we go to the next one? Okay. So this is showing why applanation is so crucial. So here we can already see it's a little bit off center, off to the top right by a little bit, but I think I can still applanate. I'm trying to get it centered. I'm trying to get it right. It's a little off center. You want 70% applanation before you hit suction. So it looks like I'm kind of forcing it. It's a little off center, top and right. Good. So we got suction. So I forced it, it happened, but then it broke. So that's exactly the good thing we didn't start the laser yet, because it wouldn't have been great to have started the laser and have suction break. So that's why this technique is more challenging for the surgeon to do, because that applanation is so crucial. The centration is crucial, and patient cooperation actually during that point is actually very important. So let's look what happens when the suction break happens during the laser portion. Not a great, and I'm showing all of my, challenging cases that happened because I didn't want to show a perfect case, because that's not interesting. So here we are again, we're not perfectly centered, but we got applanation, or we're getting it, we're about to get it. Okay, sort of forced it, we got suction. There it is. There's the suction. Okay, so I'm happy. It's relatively well centered from my point of view, even though cornea is a little bit off. And so here we're starting the laser. We are doing the posterior aspect first. And then now you can see it on the left, upper left. It's about to break, but it hasn't broken yet. And the laser is about to go. That's the anterior part. It's about to break. You can already see it. And I stop the laser before it broke on its own. So now we have a partially completed lenticule. What are we going to do? We had basically, if you're looking at the cartoon, we had the posterior, we had steps 1, 2, part of 3, and not 4 done. You can't really do anything with this at this point. You could abort and do PRK, which is not the goal. You can't really do LASIK on top of this at this point. So what you end up doing is you are able to redock, and the laser is able to go back into the same plane, but it's very challenging. I redocked this several times, cleaned the corneal surface, cleaned the laser. But the view is a lot more challenging because you already have the laser that's created the planes. Here we created suction. You can see that about a third of the anterior cap cut has already been done, but the laser here found the same plane, and it's now going to create the rest of that anterior cut, the anterior cap. And the rest of the case went perfectly. The patient was 20/20 minus on post-op day 1. So just wanted to show how to get around that if that ever happens. So this was an interesting case. So this was so I'm going to show the next step. So once the laser's gotten the lenticule out, you're opening the cap opening incision, and you're going to, I'm going to actually fast forward the part that goes correct. And so you're going in there. You can see this patient had a lot of neovascularization from contact lens overwear. I just put a drop of bromonidine to limit that little bit of bleeding, and we're going to blot it as well. So then we go on to the lenticular adhesion. So I'm opening up the lenticule now. So you're going anterior into that pocket first. And the anterior part, you want to sweep all the way across. So it always helps to take a Colibri and hold the eye steady as we're doing this. So we're going to sweep all the way across. A common mistake that can happen here is when you confuse the anterior and the posterior planes. That's easy to do. So very careful to do that. And now I'm about to go into the posterior plane, very careful. So you can sort of see that that pocket initially is a lot smaller than the anterior one I made, and you want them 2 different sizes to differentiate. And here I am just checking again that the anterior one is super loose and open, and it is. So now we're going to go in with the other side of the spatula, put a drop of BSS onto it, and we're going to dissect the anterior plane. So my usual technique is to go to 6 o'clock with these side-to-side motions. Depending on what energy you use, the adherence is always slightly different, but here we are kind of going all the way. And you're going to hear a pop 360 degrees as it breaks that edge there. So this is breaking the anterior part of it. This is all going smoothly and correctly. Now we're going posterior. So posterior, I go also to 6 o'clock all the way. Okay, great. And then I go usually to the left, sweep, I create, but not all the way. And then I come out a little bit and go to the left again, but I intentionally left a pocket there for adhesion. Then we're going to go all the way around. And so now this is completely okay, great. So we've done the anterior, we've done the posterior. Now usually you swoop it around a little bit and it comes out. So that's the ideal. It's not coming out, and that's okay. So if that doesn't happen, still sweeping, trying to figure out if there's any adherence at all. But now I'm going to go in with micro forceps and pull it out because it's completely dissected, and we should be able to pull it out pretty easily. I'm going to fast forward a little bit. The point here is that it would not come out. It would not come out with the micro forceps. I went back in with the spatula, dissected. Here we are dissecting a little bit more. I repeated this several times, and at this point, it just wouldn't come out. So what do you do at this point? It's stuck in there. This is the fear that, well, what do you do if you just, it's adherent? You can't get this, the lenticule out. What are you going to do? So the technique to do here that worked pretty well is I went in with the micro forceps, grabbed whatever I could. Or I guess maybe it's on the next one. Let me go to the next one. Okay, so here we are. So we're going in with the micro forceps. We're going to grab it. And then this is a technique that worked very well. With my left hand, I'm going in with the spatula again And now that I'm holding it with my right hand, I'm going to dissect now with my left hand.
Can you tell if it's the underside or the upper side or where it's stuck?
I couldn't. This is why this particular case was so challenging. I couldn't see, and you can't really feel at that point either, because essentially it's sort of, adhere. It's one piece is on top of another, and so you can't tell. And mind you, this wasn't one of my first few cases. This was probably 10 through 20, which goes to show you, don't relax. You can have a hard case even after you've gotten past the first few beautifully. And so there we go. There, I finally felt the pop. I think it finally came out over here. I'm going to fast forward a little bit.
Ashwin does a lot of smiles, so maybe he has a comment.
Yeah, I'd love to hear. Here we go. I finally pulled it out and I'm showing. Yeah. So I wanted to be extra careful that I got the whole thing out.
Yeah, you can have a toned lenticule like this. You can have the cap, fix on top, especially after the toned lenticule. Those are really, really challenging. Something that Glenn Karp talks about is how to get away from these situations by using the reverse technique. So rather than doing a cleavage plane that we are trying to do, he takes a rod that directs towards your face, and you can still get away from cap adhesions in this format. And I'll send some videos. It's there on YouTube as well. A lot of these escape videos. How do you escape once the cap is stuck to the lenticule stuck to the cap?
Yeah, that'd be very interesting. If you post those later. I irrigated this case in the interface. I don't usually irrigate because you get corneal edema on post-op day 1, but here I was in that surface for so long that I wanted to, and I think he was 2050 on the post-op day 1. So, but 2020 after. So let's move on briefly to ICL. I know we're kind of limited on time. So ICL was another option I wanted to offer patients. And here we could increase the diopter range to even a -15. So a plus 16 or a 16 diopter ICL lens corrects for a -15 at the spectacle plane. Really, you can correct higher prescriptions. So I did someone recently who was a -17, -18 and left them a little myopic, but they were thrilled. Same thing with the stigmatism, it's 0 or 0.75. You can't treat 0.5 or 0.25 astigmatism. You're obviously not correcting hyperopes because their AC depths are usually shallow. And you do have to have an AC depth 3 millimeters in the US. Outside the US, it's 2.8. I don't think that's a hard rule, but it's sort of a recommendation. And the benefit of this procedure is that there's 0 corneal touch. There's no applanation. There's no subconj heme during. You're doing bilateral surgery, unlike RLE. There's, I wouldn't say no dry eye, but even less dry eye because there's really no corneal. The only corneal incisions are ones similar to that of cataract surgery. And, there's a better quality of vision. There's no higher order aberrations. But, the limitations are there's no presbyopic options in the US yet. And the data with Viva outside the US, I think, is not perfect, but it's good. And there are other post-op risks because we're now entering the eye. I don't think they're as great as they are with RLE, but, you're inside the eye. So there is technically a risk of an RD and endophthalmitis. There is risk of corneal edema, and I've seen that when I had to reload a lens and a patient had a floppy iris and it kept collapsing. And of course, the sort of dreaded complication why the EVO lens that just came out is better than the Visian is that, it has the pre-made holes and you don't have to do peripheral iridotomies in advance is the IOP spike initially that we want to avoid. I thought this was interesting that ICL had lower rates of higher order aberrations compared to wavefront guided LASIK. So they did sort of a head-to-head prospective case series. They compared they looked at patients -6 to -9. And this is the question you have, right? Someone who's a -13, they only have ICL or RLE as an option. What do you do for the myopes that are candidates for SMILE, PRK, or ICL? Why would you recommend ICL, which is in theory a more invasive surgery, but I do think that the quality of their vision is better, and there's no corneal nerve issues afterwards. So in this one study, the ICL group had lower induced aberration of the HOAs compared to wavefront guided LASIK. And there's no significant difference in contrast sensitivity between the two groups at a photopic level, but a mesopic level, there was a difference, and ICL was better. And there's a ton of data on this, and I think this is one of the main advantages, I think, is that the quality of vision with ICL is better. And I'd be curious, Ashwin, do you do ICL as well, right?
Yeah, lots of them. Yeah.
Yeah. And so what are your thoughts on the argument of the, decreased HOAs, and how do you think about that?
I think it definitely makes a lot of sense. In fact, we've started to do a lot more lower powered ICLs as well. I mean, usually the norm has always been above 10 is where you do this thing. And we also do a lot of these ICLs in places where there is no refractive machine available. For example, in Africa and stuff, we have to do ICL. There is no other option, number one. Second, what we are seeing is the post-op day one result of an ICL is probably equal or even better from a patient satisfaction standpoint. It's probably even better than the refractive in a lot of cases. And, it makes us really think that, machines like iTrace and abrometries, make a really huge difference in analyzing these pre-op and post-op, specifically because the abrasions are something which are not picked up in most of the devices. And when you start picking them up and you start analyzing this deeper, ICL is a way, way, way far better option, provided there is also a caveat here. It's still an invasive procedure, number one. More important is you're still dealing with pupil issues at that point. Sometimes you never understand the real sizing because we're analyzing anterior chamber depth and we're analyzing white to white, which both of them are misnomers because we're going in the sulcus space. So what we really need to analyze is the sulcus space where the ICL is actually going and fitting. So if it is creating a higher vault, you're going to be causing a dilated pupil postoperatively. So there have been instances in the past 4 or 5 years that I have had to remove a couple of ICLs. So that does happen, but the law of averages definitely states that the patients are far happier in ICLs than in LASIK in some of these cases.
Yeah, I'll just make a quick comment. Oh, just that I've also, with the Evo, I've gone out for my -3s and -6s. I'm offering ICL as first line, and it's been working just beautifully for this group of patients for the low myopes.
Yeah,
Beautiful presentation so far.
And believe me,
as well, Bill, with the Evo and the fact that you can correct the toricity now, those are completely different than years ago. Couldn't correct astigmatism, and the vault isn't quite as much of an issue with the Evo. We can be a little lower vault, maybe healthier to the anterior surface of the lens, so it appears that the rate of cataract is significantly lower also.
The central hole is actually the game changer that completely changed the way we look at ICLs. We used to have a lot of uveitis and uveitis in the first day post-op. It's all gone. That central hole. Just wanted to add that.
Yeah,
and just to, I was going to mention, this has been so great. I know we have about 5 minutes left or so, so I just want to make sure we stay on time and everything.
Yeah, we're wrapping up. And I think it's interesting, Ashwin, that, in the US, this is sort of the premium procedure. And it's a lot more expensive for patients. But you're right. You need access to a laser to be able to do the other procedures, which you don't have. And really all you need is you don't even need a phaco machine for this. You just need a microscope, which is pretty amazing. So, we can look through, I'm going to skip the loading video. I don't think that's as interesting, but my point with the loading is that it's harder than it looks, and our scrub nurses for cataract surgeries do a good job. So I think there's a few pearls here, and this is obviously a toric case because the patient is marked, but when you're doing these paras, you want them parallel to the iris plane. You don't want them going down, how you usually do with cataract surgery. When you're making and putting in some occiput management, you want enough to protect the endothelium, of course, but not enough that you're going to have a post-op spike. For the main wound, also parallel to the iris plane and large right away. I think this is a 2.8 that blade, so you don't have to later on. And I think that the unfolding is actually kind of the key to all this, and it almost feels like DSEC surgery in a way. And so here I'm inserting, and I'm way too far into the eye. It's better done when you're sort of just right at the wound and you let it unfold. Here I'm too far in the eye, and it's going to go in, and it's going to go in like a taco, and it's going to stay like that. So here it is. It's a taco. It's in the eye, but it's not unfolding. It's not unraveling at all. So it's just sitting there. So I'm going to go in with that first pair, and I confirmed that the hole is in the leading right haptic, and I'm just going to inject a little oxycodone and have it open up, and there it goes. And then you position with the manipulator, and so averted. So there it goes. It opened up. And one last surgical video. So here, we're going in a little bit, and here it's opening up to the right. And the trick that always helps, and I noticed that it's opening to the right, so I'm going to twist and sort of go to the left. And the imagery that I think one of the star gurus told me was think of it like landing a plane. If you're a little tilted to one side, you got to sort of adjust and go to the other. And this is great because it unraveled, and the two leading haptics went in without me needing to manipulate them. So exactly what we wanted. So just wanted to say thank you to everybody who watched. These are some of the cartoons that I'm working on with Mort Gerberg. I thought they would be funny as a last slide. So thank you to the celebrity panelists for your great insights. And of course, obviously to Dr. Agarwal and Dr. Trattler for moderating. I think it was a really wonderful discussion tonight.
Kudos to you, Yuna. Really, being in a solo practice where you don't have someone holding your hand, or an attending, or a colleague, or a partner, and you're doing this on your own with a very steep learning curve. Kudos to you. Beautiful.
Very impressive, Yuna. Really nice.
Thank you.
Yuna, first of all, thank you so much for your insight, because this is something so innate and intrinsic to every single surgeon across the world. I'm sorry, my electricity just went out. We'll come back to it. But this is very, very innate and intrinsic to every single surgeon, whichever level they are at. They always need to have innovation coming into the innovation does not have to be something new, right? It is something new that you're doing is innovation in itself. So, and then that really takes a lot of effort. I think one of the comments that everybody feels and relates to what you're trying to convey here is you're trying to bring something new. It's a 0 to 1. You're not going to have the 1 to 100 over here. This is 0 to 1. You got to restart all that education, drive. You got to push this boundary on your own. There's nobody else who's going to do it for you. You can motivate everybody in the employee segment, but you still have to wear the owner's hat over here on that piece. So thank you so much for bringing that characteristic out in the presentation itself. But to the audience who's watching, I think it's important to know, first of all, patiently listening and sitting through discussions in this age of webinitis. We are really humbled, and we're supremely glad to support the support that we're having from you guys. Remember, we are on social media, so you can watch us on Insta, Facebook, and Twitter. This whole episode will be ready in about 48 hours on our website, risingeyestars.com. Please do go ahead and watch it. Also, YouTube in some time as well. So thank you, everybody. And we will actually have to take off now because we are 3 minutes late. But thank you, everybody, and see you next time.
Thank you.
Good night. Thanks. Great job, Yuna.
Thank you.
Are we off?
One